right, well, welcome everyone. My name is Ellen Barra, and I'm a member of our Provider Outreach and Education team for WPS Government Health Administrators. With me on this video today is Dr. Joelle Vlahakis, our Contractor Medical Director. She is overseeing a CMS challenge to increase the use of chronic care management services for our Medicare patients. In this video, we will provide just brief information on the value of chronic care management for both the patient and the provider community. We're going to concentrate on one aspect of the care plan, and this is the expected outcomes and prognosis. We have multiple YouTube videos available on chronic care management. We have recordings of webinars that we have provided. These are under the playlist Chronic Care Management on our YouTube channel. So Dr. Vlahakis, can you provide us with some information on the value of chronic care management for our Medicare beneficiaries and our providers?
Sure, Ellen. So I am internal medicine and pediatrics trained and spent some time the last decade or so doing hospice and palliative medicine. I am very interested in what happens to my Medicare beneficiaries, right, before they need any of those kinds of services, because I worked in an acute care environment. And I can tell you, no matter how nice I was or how wonderful the hospital food was, no one liked a hospitalization. They were away from their families, their pets in some instances, and all found it extremely disruptive. I often wish that I had an opportunity to work with some of these patients and families ahead of that hospital stay. And that's exactly what chronic care management tries to do. We always try to provide a holistic approach that encompasses not only the patient, but the family, because illness truly is a family experience. What I love about chronic care management is it extends that even further to the community. The idea behind chronic care management is that if you provide a proactive approach rather than a reactive approach, you can head off issues and problems, sometimes simply with a little education and conversation and some support, maybe not only from you, but from other resources within the community. It's a very different approach to care, and it can be a little strange at first for those of us trained in traditional medical models, which really do more of a problem assessment solution type response. This is very different. This is that upstream response that I wished I could have provided in the hospital setting for my patients. The really nice thing about providing this kind of care is it's also very satisfying for providers. And when we first started this project, Alan, I think I remember telling you I was a little concerned. I myself was also coming off of an experience with the pandemic, which was really trying and challenging. And we were very concerned about the level of burnout in my fellow physicians. I didn't want to add something else to the things that they needed to do. But what I found is for those providers who have figured out a way to do this well, it has really enhanced the quality of their work life. And that's one of the reasons I can really get behind this program, and I'm really enthusiastic about making sure people have what they need to do it.
All right, thank you, Dr. Vlahakis. Just to provide a brief overview, chronic care management is a patient-centered approach, just like Dr. Vlahakis mentioned, that addresses a patient's chronic conditions and overall health. The development of a care plan provides for a more whole person care rather than episodic care. CCM also allows for more patient involvement in their own care, in their own health, working with that clinical staff, providing that care management. It encourages the patients, in some cases, because you have some patients who are not going to, but it encourages most patients to really pay more attention, to listen to the education that you're providing, and to make those needed changes that will actually improve their health. The goal, of course, of chronic care management is to reduce the patient's need for an emergency department visit, a hospitalization, and also those more urgently needed in-person encounters where the physician or practitioner is kind of having to work that patient in as opposed to being able to stay with the schedule that they have planned for the day. Well, one of the requirements for providing CCM is to develop a care plan. And I'm going to pull up a document here real quick. So the document I have pulled up is a CMS document again on chronic care management. If we go through this entire document, which we're not going to do today, it provides you with the requirements for the patients. They have to have 2 or more chronic conditions for chronic care management or complex chronic care management, or 1 single high complex uh, condition in order to do principal care management. So what I want to show you in this document is the comprehensive care plan. And so in developing your care plan for the patient, these are the things that you'll need to take a look at. So what we're going to talk about today is this one right here, which is expected outcomes and prognosis. We have provided education to multiple physician groups, physician practitioners, organizations, etc. And one of the questions that comes back is, well, how do I determine this expected outcome and prognosis? So that's what we're going to ask Dr. Vlahakis to talk to us about today is really how do you know what needs to be included in that expected outcomes and prognosis for your particular patients?
So, Ellen, I think of all the skills that physicians acquire, prognosis is probably one of the most difficult. When I train hospice and palliative medicine fellows, one of the things I was famous for was really taking them to task and forcing them to come out with a prognosis. What I wanted them to get used to was being, quite frankly, wrong or incorrect. Much of the time, physicians are uncomfortable with rendering a prognosis, but I'm hoping to give you some guidelines and some assurance so that when you do think about these things, you have a little more confidence doing it. I think first and foremost, the most important thing to consider is that you're rendering a prognosis for a patient, not necessarily a specific diagnosis. It's a holistic overview of everything they have going on, which makes it more challenging, of course. But I think it's important to remember that you're assigning these things in a global way. I think it's also really important for physicians to recognize they're going to be incorrect much of the time. But what I would challenge you to do is think about that patient that perhaps is frail, that has been battling maybe a number of chronic illnesses, some of which have landed them in the hospital setting. They may be of advanced age. They may have started to have things like pulmonary cachexia or more and more difficulty maintaining their euvolemic state and heart failure, and compare that to someone with perhaps a similar diagnosis profile. Maybe they have mild heart failure, maybe they have mild COPD, but they're 65 and they're otherwise robust and active. You know those 2 patients have very differing prognoses, even though their problem lists may look at first blush very similar. So I'm going to tell you, and I'm going to put you also on the spot, you do have some inkling as to whether or not a patient's survivability is long or short. And it's okay to guess, and it's also okay to be wrong. I used to tell my fellows that the only difference between myself as a palliative provider who thought about prognosis all day long and my other physicians is that palliative providers know how bad we are at this in general. And it's okay to be poor at this, but it doesn't excuse you from not entering in some sort of decision or guideline. I also think it's really important to think about prognosis in terms of the conversations that you'll have with patients. One of the holistic things that perhaps you consider doing for your patients is something like advanced care planning. Prognosis is often a great way to introduce that subject. I'd like to talk a little bit about other things besides life expectancy that go into a prognosis. Very often when physicians consider prognosis, they feel they need to know exactly how much time a patient has left. But I would challenge you to do a couple of things. One is it's really best to consider a range rather than a finite time. So rather than saying 3 months, say weeks to months. If it's something that's a little bit longer, it may be months to years or simply years. If it's short, then we might go to days to weeks or weeks to months. Really, a range is enough to explain that what you think this patient might have left. The other thing to think about in terms of prognosis is prognosticate really means to see ahead. And that doesn't necessarily mean specific to a patient's death. It can be other outcomes. And I think that's what a really good care plan does. So think about your diabetic patient. An outcome may simply be that they have a limb at risk for amputation, or it may be that they're at risk for neuropathy. And if we don't get them into a better glycemic state, that is likely going to continue to worsen. That's a prognosis. You have just rendered what is likely to happen to the patient if the disease continues along its current course. Obviously, in chronic care management, what we're trying to do is alter that course. And I think it would be brilliant if a physician wanted to mention that in their care plan. Yes, we expect this outcome to be thus that the patient on dialysis is at greater risk for, say, cardiac events and stroke. However, because we are working on this particular problem and this is what we see, we anticipate that this patient's renal failure may eventually no longer be an issue. They may be on dialysis temporarily, and this is what our goal is. I think that's a wonderful way to render a prognosis. And you haven't even mentioned life expectancy. That is absolutely okay to do. And I would encourage all of us to try to get a little bit better about articulating what we're thinking in these terms. It takes a little bit of practice, but it really can be done. And what a service you're providing to patients and families by illuminating not only the problems at hand, but also the ones you're trying to avoid. And that is a wonderful way to partner with patients and families and get them on board with your care plan in the first place.
Dr. Vlahakis, that's very interesting information. So with the comprehensive care plan that we have up on our screen right now, all of this really kind of works together then. You have your problem list, which could be things that you as the physician are treating, could be things that other physicians are treating, or things no one's treating right now. And then that goes into, if it stays the same, here's what we can expect, but here's the measurable treatment goals that we're going to work for that could change this prognosis. Am I understanding that correctly?
I think that's the perfect way to describe it, and understand that your priorities are going to change over time, that this document is going to be very dynamic, and it's meant to be. It is how physicians think. We prioritize what we think might be most important to tackle at that time or in that office visit, and things may be relegated for later, but they never quite fall off the patient's comprehensive care plan because they're always there.
We talked about the requirement that a patient has to have at least 2 or more chronic conditions. We know, as you mentioned, some patients can have 30. One particular doctor we talked to sent us a copy of redacted documentation. The patient had 30 different problems listed on there. So as you've stated, that is going to be a little more difficult to determine that outcome and prognosis. So you would really kind of look at the whole patient as opposed to each of those individual problems. Is that correct?
I think that's the easiest way to manage it. We take care of entire patients. They're more than just a constellation of systems when they come in. They're really looking to us to try to improve their quality of life and hopefully their longevity. But yes, I think that's exactly right. You may need to focus on one or two dominant chronic medical conditions that perhaps are driving the prognosis. And it may not matter that they have toenail fungus if they also have a very terrible cardiomyopathy. Those things may go together. We can all understand that their oxygen carrying requirements may be diminished, and that may be contributing to the toenail fungus. But of course, you're going to, with intelligence and with your physician backgrounds, and I'll also say your physician intuition that you've developed over time, render a prognosis that's reasonable, and you can at least construct the rest of the care plan around.
Okay. Now, with chronic care management, a lot of the services that go along with this, including developing a care plan, can also be done by the clinical staff. So when a clinical staff person is providing the service and working on developing that care plan, it's under the general supervision of that billing practitioner. So from what I'm understanding, your clinical staff is going to be involving your physician in helping to develop all of that care plan, even if it's not that the physician themselves is developing the care plan. Is that a correct statement?
I think that's absolutely true, and I think a good bit of a care plan has an interdisciplinary approach. So you're still going to be able to see the impact and the influence of that physician provider. I can't imagine, for example, a clinical team member rendering a prognosis or even an expected outcome. I could easily imagine, however, that clinical team member and the physician having an interaction where there's an exchange of information such that that clinical team member is able to relay that the patient isn't doing as well. They're even having a hard time, for example, getting out of bed. And then the prognosis is going to change. The physician's going to change that prognosis. However, it's because of that interaction with the clinical team. And it may be that clinical team member that reaches back out to the patient to suggest things that the physician thinks might be helpful at that point.
Okay. All right. Well, Dr. Vlahakis, we appreciate the information that you provided here today. If you have found this information helpful, please like and share the video. If you haven't already, please subscribe to our YouTube channel. We post new videos on there all the time to assist you in really knowing and understanding the Medicare rules and regulations. Please take a minute to take our survey. Okay, so what you have up on your screen right now is a link in this section right here where you can take a survey on this particular video. You also have a QR code that you can use with your smart device, and it will take you to the survey. We want to hear back from you. Part of what is included in the survey is not only your opinions and thoughts on this video today, but there's also an opportunity for you to provide suggestions on additional education that you may want to hear about. Also, we want your comments. You can comment on a YouTube video. We want your feedback. We want to hear the questions and concerns and things that you may have about the information that we have provided for you today. So we just want to thank you very much for taking time out of your busy day in order to listen to this video. Thank you very much.